Welcome to everybody. My name is Kelly Pfeiffer. I'm with the California Healthcare Foundation. I'm a family doctor, a buprenorphine prescriber, and I joined the foundation about a year and a half ago, and CHDF is very proud of our new efforts focused on the opioid epidemic. We've got a real treat for you today. We're going to be focusing on expanding access to buprenorphine in primary care practices, and the timing really couldn't be better. About a year ago, the federal government announced a new initiative supported by Secretary Burwell focused on expanding access to medication-assisted treatment along with improving safer prescribing practices in naloxone. And those three areas, safer prescribing practices, medication-assisted addiction treatment, and naloxone have been the central focus of CHDF's efforts for the last year. One of our big projects is supporting opioid safety coalitions, and these are groups of local people, hospitals, medical societies, public health departments, community advocates, addiction treatment clinics, who all together are looking for local solutions to address our epidemic of opioid overdose deaths. And medication-assisted treatment, specifically how to get buprenorphine available for Californians, is a big piece of this initiative, because we know that only 1 in 5 people who need buprenorphine treatment is able to get it. So CHDF commissioned this paper because we saw that methadone clinics alone, opioid treatment programs, can't possibly meet the demand for the new generation of people with opioid use disorder and addiction. And primary care is really well positioned to help. We in primary care, and I include myself, were part of this epidemic, and because of liberal prescribing habits, which have a long history based on misinformation from drug companies and pain is the fifth vital sign. There's a lot of literature about how we got to the place we are, but it's very clear that because of stigma, the only place people will be willing to go to get help may be their own primary care clinic. And so primary care clinics stepping up to be able to help this population of patients can really make a difference in this opioid epidemic. 36 clinics across California were funded by HRSA to the tune of $300,000 or $400,000 a year to integrate addiction to primary care. So we were very excited that this paper came out just as those clinics are starting to launch their practices. And we really think that what we learned in this process of researching this paper and in what we're going to share with you in the webinar today could be very helpful. So Barbara Masters and Mary Rainwater, both experts, national experts in behavioral health, interviewed practices around the country to find out how actually clinics did it. What were the main things the clinics needed to know to be successful in integrating buprenorphine? What were some of the challenges they faced, and how did they get through those challenges? This webinar is principally focused on the use of buprenorphine for addiction. However, it's a real exciting opportunity in primary care for buprenorphine in pain as well, which won't be covered here. But I did want to mention that the more primary care providers become comfortable using buprenorphine for addiction, the more opportunities we have for people who are on high-dose opioids, whose pain is not controlled, who may be having medical problems, and certainly are high risk of death and bad outcomes from these opioids. Switching to buprenorphine can be an option to improve safety, improve pain control, lower medical complications, and lower death rates. And so the more of us in primary care who become comfortable with this medicine for addiction or pain, the better off we'll be. I briefly want to go through today's speakers. James Gasper is a clinical pharmacist and addiction expert who had many years in the public health system working in addiction treatment and now works at the California Department of Healthcare Services, and was largely responsible for getting the authorization requirement removed from Medi-Cal. So now if a buprenorphine prescription is written for Medi-Cal patients for opioid use disorder or opioid dependence, there's no TAR or authorization requirement, and that was a huge gift that he helped us with last year. Mary Rainwater and Barbara Masters, as I mentioned, both behavioral health experts, will be co-presenting today, and they were the authors of the paper. And we also have a treat. We have 2 primary care doctors who practice in clinics in rural California who will be calling in to share some of their experiences and some personal stories of how they've used buprenorphine in their. So next slide, a little bit of housekeeping. We're going to be, everybody's on mute as we have a large group of people here. and we will be collecting your questions. And then when it's time for the question and answer section, I'll be curating those questions and teeing them up for the speakers. All right, I'm going to turn it over to Barbara and Mary.
I actually think James Gasper is going first.
Right.
I'm so sorry, you're right. I got out of order. James, please take it away.
Thank you. Do I have screen control yet?
I don't. We're going to need a minute for James to be able to get the slide deck on his screen. I don't see it on the screen yet. Robert or Ravi, can you make sure that he's got screen access?
Okay, I just giving you access right now.
There we go. Thank you.
Okay, no
problem. I apologize. Please stand by. Here we go. We're good to go.
All right. Thank you. Thanks, Kelly. This is James Gasper, as she said, and I'm going to try to lay some of the foundation work before we get into the elements of implementing buprenorphine in primary care. There's a few things I want to cover. First is kind of the landscape across the state, both of the availability of treatment as well as where the opioid overdoses are happening. And then I'm going to get in a little bit onto buprenorphine itself, what it is, where it came from, its availability, both in formulations as well as from a formulary standpoint through Medi-Cal. And I'll go over some of the statewide initiatives just to reiterate some of the stuff that Kelly already brought up. So the first thing that I want to point out is that there is a disproportionate distribution of deaths across the state. They primarily are happening in rural communities in the northern part. And you can see our statewide average for opioid overdose deaths is about 5 per 100,000. In some of these rural communities, the number's between 20 and 25. So there's a concentration of overdoses. And unfortunately, there are some associations with these communities as well as far as the availability of opioids. For example, the prescribing rate of opioids in these counties that have the highest overdose rates, it's about 1,000 prescriptions per 1,000 residents, whereas it's half that in some other parts of the state. So we know there's some contributing causes to this, but one of them that I'd like to propose is that we have a lack of access to treatment. And if we look at the availability of methadone maintenance, which has been the gold standard for opioid addiction for probably the last 40 or 50 years, we see that these same communities don't have any methadone clinics. So the only way that we can begin to fill this gap is with medications like buprenorphine, and that's why it's so important that we're talking about it today. Buprenorphine is portable. It's something that really just requires somebody with a Data 2000 waiver in order to set up shop. Methadone clinics are much more of a fixed commodity and have a large cost to set up and to establish. Something that can't be overstated enough is that the more treatment we have, the fewer people die from opioid overdoses. And this is a study out of Baltimore. And you can see that there's an inverse relationship between the overdose deaths and the availability of methadone and buprenorphine. As they went up, overdose deaths went down. So we know that the more treatment that's available in a community, the fewer people will die from opioid overdoses. So what about buprenorphine? It's a drug that's been around for quite a while. It was originally discovered back in the 60s. And during early development, it actually was listed as a C2, which would be the highest level of abuse, something on the order of oxycodone products. But once it got FDA approval in 1985 for pain, they moved that to a C5, which is the same as something like Robitussin AC. It was available in injectable low-dose form for analgesia, mostly in the operating room, had very limited use outside of that. So there wasn't a whole lot of concern about abuse or diversion. right around 2002, a few things happened. One is that the Drug Abuse Treatment Act of 2000 was signed, and I'm going to tell you more details about that in a minute. But that came with it a change in the scheduling of buprenorphine. The sublingual products that were approved in 2002 were indicated for the treatment of opioid addiction. They were much higher doses, and they were going to be prescribed and dispensed out of community pharmacies. And honestly, the DEA saw this drug going from being a hospital-only product to something that could have pretty wide distribution. And they re-looked at it and realized that its potential for abuse was probably far higher than what its original scheduling, so they changed it to a C3. And the good news is that it still is a medication that can be called in and can be refilled in California up to 5 times in 6 months, maximum of 120 days supply. So it's easier to prescribe even as a C3 than a lot of our potent opioids like oxycodone and hydromorphone and morphine. If we fast forward towards 2010, there was a transdermal patch that was approved for pain, and just last October, a buccal film became available. So a lot of people want to know, how does buprenorphine work? Well, it's an opioid, but it's a partial agonist, and a partial agonist doesn't have the full effect of a full agonist. There's a limit to how much it turns on the opioid receptors. Some of the important components of it, actually this is intrinsic to a partial agonist, is that it binds with high affinity. So one of the ways that medications work for opioid addiction is you block the illicit opioid from being used, whether it's heroin or prescription opioid. You block that drug from getting to the receptor and causing the effect. Buprenorphine binds with high affinity, so it prevents other opioids from causing the high that would be desired. It also dissociates slowly. This drug has a long half-life. It's about 37 hours, so it hangs around the body for a long time. But beyond that, it sticks pretty tightly to the receptors and stays there for a long time. So this has a stabilizing effect. So you move away from, shooting up heroin 4 or 5 times a day to a drug like buprenorphine that you can take once a day. It decreases the withdrawal symptoms, and it blocks any of the good feelings that would come from using heroin, and that's really in line with what methadone offers. So back to the mechanism, as a partial agonist on the mu-opioid receptor, like I said, that causes the pain relief. It decreases the cravings, decreases the withdrawal. It's also responsible for the euphoria, but as a partial agonist, there's a limit to how much comes with that. It's also the part of the drug that slows down your breathing and causes the GI side effects. One of the other properties of buprenorphine is that it blocks the kappa opioid receptor, and it appears that in withdrawal, kappa opioid receptors are activated, and that's part of what causes the dysphoria that comes with it. It also may play a role in depression, and many of you may have heard that there's been some studies recently looking at the antidepressant effects of buprenorphine, and we believe it might in part be related to its ability to block the kappa opioid receptor. So a little bit more about what a partial agonist is. If you think about a dimmer switch for a light, if you were to turn it all the way on, that would be the action of a full agonist, which is morphine, heroin, hydrocodone, etc. A partial agonist actually stops halfway. If you were to turn the dimmer switch up halfway and stay there, that would be a partial agonist. So it turns on the light, but not to the same degree as if it was fully bright. And an antagonist, which would be naloxone or naltrexone, the light wouldn't be on at all. So that's kind of the spectrum of opioid activity, and that's what a partial agonist looks like, which is what buprenorphine is. One of the benefits of a partial agonist is that there's a limit to all of the physiological effects. So even at higher doses, I'll go back to this chart briefly, even as you increase the dose, there's a ceiling to the effects of the drug. And when we're talking about toxic effects like respiratory depression, that imparts safety profile into it. And sure enough, when studies were done at increasing doses, 2, 4, 8 milligrams, there wasn't really any difference in a number of physiological measures. In particular, respiration rate. We know that if you are exposed to too much of an opioid, you can shut off your breathing and you can die. In the case of buprenorphine, because there is this limit on the amount that it slows down breathing, it's actually very safe, even at higher doses. This also applies to the subjective effects, such as getting high or drug liking. So as you increase the dose, there's not a whole lot of change in that either, which may limit its abuse potential. Along those lines, buprenorphine has a really wide therapeutic index. And a therapeutic index is the relationship between the lethal dose and the effective dose. So the greater the therapeutic index, the safer the medication. And you can see that buprenorphine's therapeutic index is about 30 times that of morphine. And this is part of the reason why it's an appropriate drug to be used outside of a narcotic treatment program. It's something that can be prescribed, it can be dispensed from a community pharmacy, and patients can take it at home without a lot of oversight because it's a safe drug and there are limits on its ability to cause adverse effects. And as I said before, it doesn't have as much drug liking associated with it because of the partial agonist activity. So these are all important aspects of it. One of the early published studies I'm just presenting here, we can see that it's effective in either formulation. There's buprenorphine alone or buprenorphine with naloxone. You can see the negative urine sample. It's fairly low, I think, by a lot of people's standards, but one thing I want to impress upon you is that this was only a 4-week study, and if you follow people over time, you'll continue to see fewer and fewer opioid positive urine, so these numbers only increase. Something else that Kelly brought up in the introduction is buprenorphine's role in pain. Because of the hazards of full agonists and the lack of benefit in many of our chronic pain patients, there has been some interest in converting pain patients from their full agonist, such as morphine or hydrocodone, to a medication like buprenorphine, which is inherently safer and is actually a fairly good analgesic. I just wanted to show you a brief study that looked at that. Excuse me. What we have here is a group of patients that were on an average of 550 milligrams of morphine, and they were converted over to buprenorphine, and their pain got better, and it really didn't matter what dose of morphine they were on. All the way up to greater than 1,000, we see that their pain scores decreased from around 7 on average to about 3. So this is a small group, but what it shows me is that we can make some progress, not just in pain control, but improving the safety of opioid regimens by switching to buprenorphine. So what formulations are available? In 2002, the original product that was approved was buprenorphine and buprenorphine with naloxone sublingual tablets, and they're indicated for addiction. More recently, there's been a buccal film that has higher bioavailability that's also indicated for addiction. The transdermal patch for pain. There's also a low-dose buccal film that's approved for pain, and then the injectable that we started with back in 1985. So there's been quite a few different formulations brought to the market in the last 15 years. So what's this Data 2000 waiver that I mentioned earlier? Well, The long and the short of it is the Narcotic Addict Treatment Act of 1974 said that in order to provide methadone maintenance, you had to be registered. You know, the DEA requires a separate registration, and that's the only way that you can treat somebody with opioid addiction with an opioid agonist was in, you know, the four walls of an NTP at the time, and you had to be registered to do that. Data 2000 says there's an exception to that, and the exception is if you are a qualified physician, which means you've gone through the 8-hour training, or there's a few other ways that you can meet the qualification, you can get a waiver from being registered as a methadone clinic, but only if you use FDA-approved drugs that are C3 through C5, and fortunately buprenorphine fits into that category. One of the caveat is there's a limit on the number of patients that you can treat with buprenorphine with this waiver, and it's 30 in the first year, and you can increase that to 100 after. And there's a rule right now that may increase that to 200, so we may be looking at expansion. So prescribing buprenorphine. It really comes down to the indication. When we talk about pain, anybody that has a DEA number can prescribe it as long as a C3 is within their license, their DEA registration, they can prescribe it for pain. And this could be the off-label prescription of one of the formulations approved only for addiction, or it could be any of the forms that are approved for pain. It really doesn't matter. When it comes to addiction, if the indication of the drug is for the treatment of addiction, there are more restrictions. And the first is that you have to be a Data 2000 waiver physician, and that's the X number. It's the more common term for it. And you can only use the FDA indicated products. So you can't use the film, the low-dose film, or the transdermal, or the injectable for the treatment of addiction. You can only use the FDA-approved products. So the more common scenario that you're probably all familiar with is patients that have pain and addiction. And I get a lot of questions about how do we address this. And it really comes down to what's your intended use for buprenorphine in that case. If you're using it as an analgesic, then you want to follow the recommendations for pain. Any of the buprenorphine products, anybody with the DEA number. If you are using it with the intended purpose of stabilizing their addiction, then you have to have an X number, and you have to use one of the FDA indicated products. So it really depends on what the intended use is. And again, this would be in the same person. So how does Medi-Cal coverage work for this? Well, as of June of last year, let me back up a second. Buprenorphine, along with other medications for substance use disorders, for opioid dependence, are carved out from managed care plans. So they're all paid for by fee-for-service Medi-Cal, and that's regardless of the indication. The carve-out applies to the drug, not the indication. So if you send a patient to a pharmacy and they submit it to their managed care plan, it's going to bounce off and say something, you must bill fee-for-service Medi-Cal. When they send it to us, as of June of last year, there's no TAR required if you are a Data 2000 waivered physician, if that's the prescriber, and it's being used for addiction treatment. Outside of that, all other forms and indications are going to require a TAR. I'm going to summarize this in the table. So if we look at the formulation that we mentioned, the sublingual film and tablets and the high-dose buccal film, and it's being used for the treatment of addiction, it's FDA indication. There's no TAR required, but you do need a Data 2000 waiver. If those are being used off-label for pain, which again could be by anybody with a DEA number, a TAR is required because it's off-label, but you don't need the Data 2000 waiver. Both the products that are used for pain, the transdermal patch and the low-dose film, do require a TAR. They're not on the contract drug list. And you don't require a Data 2000 waiver. There's a lot of confusion around this, so hopefully this table helps to clear some of that up. So what's going on across the state? As I said, we removed the TAR requirement last June, and the good news is that, we just about doubled our buprenorphine access by removing the TAR last year. We've seen a 100% increase in buprenorphine claims, so that's been very helpful. We also issued an all-plan letter to our managed care health plans, reminding them that they must cover physician services when they're prescribing buprenorphine as part of managed care in the primary care setting in particular. The drug Medi-Cal organized delivery systems is something that's been rolling out in different regions of the state, and it'll be providing a full spectrum of addiction treatment services in the community. The CDC grant is addressing several areas, one of which is PDMP use, also health plan policy initiatives. A third is doing direct outreach to some of these high burden communities. If you think back to the first cartoon that I showed you of the state that has the overdose rates detailed on it, those are the communities that we're targeting, both for physicians as well as for pharmacists. And we're looking at the core areas of safe prescribing, access to treatment, as well as naloxone. Kelly mentioned the HRSA funding for 36 clinics, and this is a great opportunity for us across the state to really put this into play. And obviously the Opioid Safety Coalition's network, which I believe this webinar is attached to, goes beyond just our providers and looks at it from the community level. And the California Healthcare Foundation is obviously doing a lot by sponsoring these projects and webinars, and I'm very grateful for their participation in this process. So with that, I'll turn it back over to you, Kelly.
James, thank you so much. That was very helpful, and there's so many misconceptions about buprenorphine. I think you cleared up many of them today. For any of you who are interested, we will have this webinar recorded, and it will be on our website, so other people at your sites can learn from this as well if they weren't able to attend today. Before we switch it over to Barbara Masters and Mary Rainwater, I have a quick question for you, James. If you could address, there was a question that came in about the abuse potential of buprenorphine, how a prescriber should monitor for abuse or diversion of this product. If you could talk a little bit about buprenorphine diversion and maybe address this concept of good diversion and bad diversion.
Yeah. So there's a few different ways to think about this. One is for the patient that you're prescribing it to. When it's being used for the treatment of addiction, diversion is probably a matter of dose. Having somebody on the appropriate dose and not too much is an imperative part of preventing diversion. If patients are given extra tablets that they don't need and financially they're motivated to sell them, that would be a particular issue. When we look at how buprenorphine is diverted, it's interesting. It's not like other opioids. Most people use it to get well. They don't use it necessarily to get high. So when it's being diverted and it's being bought, it's for somebody that's in between, their supply of heroin, they ran out of money, whatever the case may be. They want to feel better. They're tired of being dope sick. So it doesn't look the same as diversion of other opioids. And we know from buprenorphine programs that a lot of patients had experience with the medication when they come in the door. And we believe it's from the diverted supply, which I think has a lot to do with potentially using too high of a dose. The way to monitor for it is with short day supply, particularly early in treatment, checking a UTOX, not just to rule out other opioid use, but to make sure that buprenorphine's in their urine. And those are the best ways to monitor it. So dose and doing the toxicology and keeping short supplies, people are stabilizing.
All right, well, thank you so much. And so, Barbara and Mary, please tell us about your research.
Terrific. Well, thank you. So Mary and I are going to highlight the main findings from the report regarding medication-assisted treatment of opioid addiction. As Kelly described, the purpose of the report is to share model programs and best practices for how primary care physicians and clinics can incorporate medication-assisted treatment into their practices. Based on the research we conducted, we interviewed 18 experts in the field in California and across the country. We also identified 10 common elements for successful programs. So that's what we're going to cover on the webinar today. If you want to go to the next slide. More than 900,000 U.S. physicians can write prescriptions for opioid painkillers such as OxyContin. To do so, they must register with the Drug Enforcement Agency. However, fewer than 32,000 physicians nationwide and just 2,800 physicians in California have obtained certification to prescribe buprenorphine. And then of those, only a fraction actually prescribe the medication. Moreover, as Dr. Gasper noted, they are not evenly distributed across the state. So to increase patient access to buprenorphine, it's critical to increase both the number of physicians who have obtained the Data 2000 waiver and the willingness of those with the waiver to prescribe the medication. We know that treating substance use disorder, in particular opioid use disorder, can feel daunting for many primary care providers. There are challenges, as the literature as well as our interviews identify. First, there's a general lack of physician training on substance use disorder. Medical school provides very little, if any, training, so many physicians may feel that they don't have the knowledge or may be uncomfortable treating people with substance use addiction. Second, as Kelly mentioned,
it's a little hard to hear you. If you could just speak up a little bit. We just got a comment that was hard to hear.
My volume was turned down. Is this better?
Yes, thank you.
Sorry about that. Medical schools, as I mentioned, provide very little, if any, training, so many physicians may feel they don't have the knowledge or may be uncomfortable treating people with substance use addiction. And then, as Kelly noted, the societal stigma associated with addiction is widespread and does extend into the clinical setting. There's not yet full acceptance and understanding in the medical community of substance use disorder as a chronic relapsing disease. Many primary care providers also don't want people with addiction, frankly, in their waiting rooms because they fear that they will be disruptive in some way. The third barrier is another kind of bias, and that is against medication-assisted treatment itself. Historically, addiction treatment has been rooted in concepts of abstinence and the social model approach, which is heavily reliant on lay people, most of whom are former addicts. Medical care and medication in particular have not been well integrated within this model. Despite substantial evidence, as Dr. Gasper described, that medication is effective, the social model field has been slow to incorporate it and often requires participants to discontinue treatment. Fourth, public policy has generally not been supportive of MAT and has imposed regulatory barriers to being able to prescribe and administer medication. But that is changing, and one significant way is the regulatory barrier that Dr. Gasper described regarding TAR that was recently removed. And Mary will speak about some other very recent developments by the federal government to make it easier for physicians to prescribe buprenorphine. Finally, as with most issues, financing is a concern. Medi-Cal does cover MAT, but it can be complicated to navigate through the various programs and revenue streams to cover the costs of the medication and the wraparound services. The recent approval of the California Drug Medi-Cal Organized Delivery System waiver that was approved last fall should help in that regard when it is fully implemented. So yes, there are challenges, but the good news is that these challenges can be overcome, and the report provides a number of programs and practices, real examples, as well as resources to help primary care practices overcome these barriers. Next slide, please. Specifically, we want to highlight models and strategies that address three core challenges. First, we describe several approaches that demonstrate how to manage the induction process, and you can move to the next slide. The process of starting buprenorphine treatment, which is called induction, can be a very labor and time-intensive process because protocols require frequent patient visits. Second, we'll describe various strategies to distribute the workload via team care. One of the main challenges that is frequently raised by physicians is that they don't have the time to spend with patients, particularly through the induction process. So being able to spread the workload is a very helpful strategy. And then last, we'll discuss strategies for expanding primary care skill sets. Our research found that mentoring and peer support are critical elements for programs, particularly for physicians new to MAT. So those are the three types of model programs and approaches I'm going to go over briefly. The first one that you see on this slide is about managing induction. New patients going through induction often benefit from personalized education, coaching, and monitoring to ensure a smooth start and to minimize discomfort with withdrawal symptoms. As I mentioned, most protocols require frequent visits during the first couple of weeks. So we found three main approaches to the induction process. The first approach is exemplified by the San Francisco Health Network office-based buprenorphine induction clinic, or OBIC, O-B-I-C. It's a freestanding induction clinic separate from the primary care clinic, although it's in the same building as the behavioral health program that the county runs. In this way, the team, through the freestanding clinic, there's a team that is devoted to administering buprenorphine. And they first can provide an in-depth assessment, orientation, and a personalized treatment plan. Patients are seen every day during the first week for observed administration of the medication. They often stay in the clinic anywhere from 6 to 10 weeks before they are referred back to the primary care provider. 43% of all patients that have gone through the clinic have been successfully transitioned back to primary care. The second approach actually integrates buprenorphine treatment into a regular primary care clinic. An example here is Health Right 360, which is a family of integrated health programs with clinics in 11 counties. Because safety net clinic patients often have many complex conditions, integration into primary care enables the clinic to manage the patients in a holistic way. Health Right 360 restructured its scheduling process to accommodate the needs of patients on buprenorphine for frequent visits during the first couple of weeks. Specifically, physicians are booked with 2 patients per hour for 15 minutes each, with the remaining half hour reserved for drop-ins or patient consultations that may require longer visits. In this way, patients needing to come back for monitoring can be easily seen in one of the drop-in slots. And the clinic has found that this system works well for all of its patients, many of whom are homeless or otherwise have difficulty scheduling and keeping appointments. I also want to draw attention to the quote from the medical director of Health Right 360 that we included. In contrast to the San Francisco clinic model, in which patients must go to a pharmacy for observed dosing, all patients who get medication at the Health Right 360 clinic do induction at home. That is, they take the buprenorphine home rather than take it at the pharmacy. This is an increasingly common practice as long as patients are monitored closely by the clinic. At each visit, for example, patients take a urine test and are assessed for how the drug is working for them. Lastly, we found other programs that do inductions through group clinics and even through the emergency department. Group clinics are also an effective way to finance buprenorphine treatment, as well as provide an instant support system to patients going through withdrawal. Next slide, please. As I mentioned, team approaches can make it easier for busy physicians to take care of patients with opioid use disorder. One leading program which has been closely evaluated is at the Boston Medical Center. In this model, physicians are responsible for writing the prescriptions for the medication, while nurse care managers oversee the care of the patients from orientation and induction through maintenance and ongoing care. Hello? In addition to providing the care on site, Boston Medical Center has received grants to do the trainings and technical assistance for other SQHC clinics in Massachusetts. I want to also let you know that the San Francisco program I mentioned earlier also utilizes nurse care managers to manage the program and be the primary point of contact for the patient. Team models can utilize a variety of allied health professionals. So a similar team-based care approach that we highlight in the report is the pharmacist-physician collaborative care model, for example, which utilizes clinical pharmacists as key team members. Both of these models report high retention rates of patients in treatment, which is a key measure of success. Next slide, please. The third collection of models help physicians and clinical staff expand their skills with regard to MAT. As I mentioned earlier, physicians need peer support and training to treat patients with opioid use disorder. This is particularly true for physicians new to this practice, but also on an ongoing basis to help with more complex patients. For physicians in rural areas who just don't have local support, Project ECHO is a widely used mechanism for providing telementoring on a variety of issues. And in the report, we profiled two different Project ECHOs, one in New Mexico and one in Connecticut, that specifically focus on substance use and MAT. And these two models represent a university and clinic-based model, respectively. But the approach is the same. They provide expert faculty, and participating clinicians bring different cases to them for discussion. A second approach, which is currently only operating in Vermont, is the so-called hub and spoke model. The basic philosophy of the model is that there are designated hubs, which in the case of Vermont are embedded in health homes under Section 2703 of the ACA. And these clinics are supported to provide a higher level of care to patients. The hubs also conduct the assessments and determine whether patients require care at the hub or are good candidates to be seen in physician offices, which serve as the spokes. They generally provide care to people with less complex addiction conditions. Hubs provide the prescribing physician with a structured program to which they can refer patients and also consultation and mentorship relationships. Lastly, although not profiled in the paper, there are two phone consultation lines. The clinic consultation warm line, which offers free phone service from addiction specialists, and the provider's clinical support system MAT program. And the phone numbers and links to those programs are included in the report. So with that, I'm going to hand it off to Mary.
Okay, let's go ahead and go to the next slide, please. And hopefully you can hear me. Okay, great. Thanks so much, Barb, for sharing the models with us. And when we did our interviews for the paper, both Barb and I were really struck by the creativity of the providers that we interviewed and how they developed and implemented their MAT, many of whom the programs had very limited resources and really demanding practices. So we, as Barb mentioned, identified, based on conversations, some practices that emerged across many of the programs and the people that we interviewed, and we wanted to elevate these as sort of key elements of success so that others who are considering implementing MAT programs could really learn from the wisdom of those that had already gone before them. So, and many of them actually, you'll see there's a lot of overlap to the models that Barb just presented, because many of them were developed really in response to some of the challenges that people were experiencing when they were trying to implement their MAT. So this slide lists first 5 of those, and the first of those is really identifying a champion for the program. Pretty much everybody we interviewed noted that it's really essential to have a champion for this approach, and that includes both a clinical champion and an administrative champion if you're going to succeed. You know, all the staff that are working in the practice environment, the front office staff, the reception staff, have to support the decision to treat patients with substance use disorders. And it's really important that executive and clinical leadership send a consistent message about that to staff and provide the training and support that's needed to work with this population in this setting. And it really can go a long way to create a climate of acceptance of people that have substance use disorders and really reducing that stigma. that Barb talked about earlier. It's also really clear that having a champion on site really helps to keep the process moving smoothly as you're implementing the project. A second key element of success is really making sure you're staffed for the administrative activities. This is really important because the U.S. Drug Enforcement Agency can conduct random site visits to offices and clinics that have buprenorphine waivers, so it's really important that you have your medical records in order, showing all the information that the DEA may want to check for. And this includes the dates and amounts of medications prescribed for each patient and documents that show that your doctors are working within the limits of their waivers along the lines that Dr. Gasper and Barb mentioned in terms of the numbers that, of patients that doctors can treat. Some clinics pull this information off their electronic health records. Others have administrative staff or medical assistants keep logs. I think the key point is to do it. You don't have to have a complicated system for doing it, but you definitely need to have record keeping in order. A third approach, a third element that we identify, which Barb just finished talking about, really is that concept of spreading the workload or using a team-based approach. That's really becoming sort of the standard of care in primary care clinics in many ways anyway, and it's really true also for those that are working to implement MAT programs. In addition to what she already mentioned about spreading the workload, it really helps also to develop sort of a trusting relationship with patients. So there are many people on the clinical team that they can work with. And again, it provides sort of a lot of support for the physician so that they're not the only one. As Barb mentioned, a lot of times primary care doctors are already feeling pretty overwhelmed, and so it really helps them to feel supported in the clinics, and they're not the only one working with the patients. A fourth and really important element of success is making sure that there's a connection to behavioral health services. So all the buprenorphine protocols and guidelines recommend that patients receiving MAT also do concurrently receive behavioral health services as part of their treatment. And this can include traditional psychotherapy, individual counseling, group counseling, and it can also include 12-step groups and social model programs, all the types of behavioral health services that are really part of a comprehensive approach to treating substance use disorders. Many of the people we interviewed noted that these services, the behavioral health services, are really important because oftentimes people who are experiencing opioid addiction have very complicated life circumstances, and the behavioral health services in particular can go a long way to helping patients deal with some of those. It can also help them identify and manage potential triggers to reusing opioid drugs. So it's really important to have behavioral health services. However, as Barb noted, not all social model programs accept the use of medication in their program. So it's really important that you identify with the patient a social model, if they want to use a social model or a 12-step one that really accepts the use of buprenorphine as part of the treatment. And then last, really important to not withhold the buprenorphine treatment from patients simply because they're either refusing to access behavioral health services or they can't access behavioral health services. Often many communities don't have the full range of support services that we'd like for them to have available to them. So it shouldn't be a disqualifier for being able to accept the medication portion of the treatment. The fifth point on this slide is about the mentoring support for physicians. So again, Barb just highlighted a couple of programs that were really successful at doing that, and I actually had the opportunity to sit in by Skype on one of the Project ECHO sessions, and it was very clear, and you could actually see the transition of knowledge, the transfer of knowledge happening, and it was clearly very helpful for the sort of the physician who was presenting a very complicated case to the team of sort of veteran practitioners at the Project ECHO about his patient to get the kind of one-on-one support and the little nuanced information that those who had been experienced in providing the MAT could offer to this new physician that was just learning how to do buprenorphine. So it really does help to provide another level of infrastructure really to clinics that are starting up a MAT program if you have that mentoring support. Let's go to the next slide, please. We'll talk about the next components. So while we're changing, I'll mention a sixth point, which is having 2 waivered physicians, if at all possible, at all times in your clinic. Now, I know that may not be realistic for a lot of practices, but it is really becoming a best practice, and it makes sense, right? Because obviously, as Barb described during the induction process, it can be a pretty labor-intensive process to start someone on the medication, and so obviously it's helpful to have another doctor who's available to help manage that. And several of the clinics and the experts that we interviewed said even if you have a second physician who's waivered and doesn't want to necessarily or can't manage a caseload, it's still really helpful to have a second doctor who can kind of pinch hit when someone's out sick or on vacation. It really does help to do that, spread the workload. So having 2 waivered doctors. A 7th key element of success is really assessing the patient readiness to stop using opioids. The guidelines for MAT stipulate that before beginning bup treatment, you have to assess the patient's current level of opioid use disorder, the presence of other drugs, and the stage of withdrawal. So this is a really important component of a successful program. But just like with other substance use addiction programs or people that work with people who are trying to address their addiction, you really need to assess what the individual patient's level of readiness is to stop using the opioids, and also look at what other support systems, natural support systems they have in place, whether that's family or friends or what other social supports they have available to them to help them engage in treatment and then stick to treatment ongoing. The 8th point on this list, Barb again shared the different models for inducing buprenorphine treatment, and it's really important that you select an induction approach that fits. Most protocols and guidelines, as she mentioned, recommend observing the patient when you're inducing buprenorphine so that you can be certain the medication is taken correctly and monitor the effects and adjust the dosing as needed. But as she mentioned, a lot of programs are now moving to a home-based induction model, and that may be preferable for the patient, and it may be something that fits with your resources. I think the key thing that we learned from our interviews is that it's really important to pick an approach that works for the resources of the practice as well as the patient's desires, and then to do that within the standards and protocols and guidelines for whatever that induction approach is that you'll be using. Another key element of success is finding a pharmacist willing to partner with the program. I mean, obviously, having access to pharmacy is a key component of a bup program, a bup medication-assisted treatment program. And as Barb noted, many primary care clinics don't dispense on-site or have medications on-site. So it's really useful to develop a working relationship with a local community pharmacy, and they really can become sort of extenders of the treatment team out in the community, and it's really important that they be available to provide easily and quick access to the medications. As Dr. Gasper mentioned, in terms of the diversion, they can also be a useful resource for making sure that's not going on, because they can alert the clinic or the practice of a patient seems to be coming in too frequently to refill their medications, and they can also sort of be the eyes and the ears of the clinic out in the community if a patient's coming in and appears to be either using alcohol or other drugs that are problematic. So pharmacies can also be really helpful. As Dr. Gasper mentioned, the billing for services can be kind of confusing, and having a pharmacy that's knowledgeable and working with your clinic can really go a long way to dealing with some of those insurance barriers. And a final key element of success that, we've already talked a little bit about today is the whole issue of sustainable financing. Obviously, that's an ongoing challenge, and many programs are grant supported and funded thanks to organizations like the California Healthcare Foundation. But we also found a lot of clinics that were really creative in how they set up their programs and structured them so they could maximize the billing, the federal or Medicaid dollars available to them to run the they run groups, and then the physician pulls the patient out of the group so that they can then write the prescription, which then motivates the patient to come to group, but also to get the prescription, and then they're able to bill for those visits because the physician's involved. So there are a lot of creative financing strategies out there that clinics have used, and it really does require sort of using your creative thinking in order to sustain the programs now, particularly the social support components and the administrative supports that are needed to implement the programs. So I'm going to just highlight one other thing on the next slide. Projects that we looked at. And if we can go to the next slide, the last slide that I want to sort of just highlight for those of you on the call today is really, as Barb said, there's a lot of new, and Kelly and Dr. Gaspard mentioned this, there's lots and lots of going on right now around the opioid addiction. I mean, a day hardly goes by where we don't see something in the media about it, and rightfully so, but fortunately there are a lot of federal developments happening, and this slide just highlights a few, though some have already been mentioned today actually, including the movement, the pending rules right now to lift the limit on the number of patients that doctors who are waivered can see. Just, I think, within the last 2 weeks or so, the final regulations came out that strengthened the parity requirements for those within Medicaid and the Children's Health Insurance Program as well, in terms of strengthening the parity around access to mental health and substance use treatment. So that's just now been finalized, and as a couple of people have already mentioned, within the President's budget and within SAMHSA, there's lots of new funding, and California has been fortunate to receive some of the new grants that have come out. And I just saw in the paper today, I think it was, that the House just passed another bundle of funding that should be rolling out eventually to help treat not only in community clinics and in other settings, but also law enforcement. So there's really a lot of federal activity underway right now to provide funding to support various approaches at combating the opioid addiction. And I think it's really imperative that those of you who are getting ready to implement programs keep in touch with your local health departments, your community clinic coalitions, the Safety Coalition that Kelly mentioned at the beginning of this call, other networks that can keep you informed of what might be available within the various communities in California or elsewhere that you operate. So with that, I'll pause and turn it back over to you, Kelly.
Well, thank you so much, Barbara, and thank you, Mary. It was a great presentation, and you did such an amazing job with this paper. If there is anyone who's not read our paper called Recovery Within Reach, I urge you to do so. It's got a wealth of information, and many of the questions that have been teed up during the chat so far, you'll see more detail in that paper. What I'd love to do is ask Bill Hunter, Dr. Bill Hunter from Open Door, if you could say a few words about your own experience, maybe even just tell us a before and after story. Bill, are you available?
Yeah, can you hear me?
Clearly, thank you.
Okay. Yeah, I didn't know, let's see, we've been doing buprenorphine in our clinic for a long time. I don't know if it's quite 10 years, but it's close to that probably. And we started out by doing heroin addicts, primarily because there was no methadone program anywhere close, and we just grew the program up organically. Lately, we've been using as much buprenorphine for chronic pain for people who either have high risk for abuse or who just can't seem to behave with their pain medications, and so it's kind of a blended thing now. Our program is structured like if you take the main addict pathway. We have people meet with a drug counselor and an RN to describe the program, to describe things, do some education. They meet separately with a provider to do a physical exam and to check about, hepatitis C or what other kind of medical issues are involved. And then we have them come in. Currently, for most of the time, we're still having people go into withdrawal and come in for a nurse visit for an induction, at which point the physician will poke his head in. If the induction is successful, which they usually are, then we give them a dose to go home, and they come back the following day to a group. They go to groups at least once, and more frequently 2 or 3 times a week for the first phase. And during one time a week they see the doctor. And as mentioned in the previous talk, the way we do it is we have the groups vary in size, but they're usually somewhere between 6 and 12 and maybe a little bit more patients who are scheduled for about a 2-hour period, hour and a half, 2 hours. And the first part of it is just gathering and doing the urine toxes and kind of checking in. And then the group is facilitated by a drug counselor and often by a behavioral health support person too. And then the doctor is in the adjacent room, and they just send people out one after another. The doctor spends usually between 5 and 10 minutes with the patient going over the lab tests, looking over other medical conditions, looking for side effects and the appropriateness of doses, and then sends them back and writes a prescription for the next week and sends them back into the group again. After people have been clean for 4 to 6 weeks then we stretch it out to every other week. And then for the ones who succeed, after that, the people are getting more stable usually, and the frequency of visits goes down to once a month, and we call that phase 2 after a few months. And then after they've been at it for a couple of 3 years, we have some patients that are very stable and are working and never vary, and we trust them enough, and we can have them come back every 2 to 3 months. And we do a similar thing with the group. They appreciate being with the groups, and we find that an efficient way to take care of it. Is that what you want me to talk about?
That's great. And I may come back to you for another question. It's very helpful to get an example of open door where you've really created infrastructure and staffing that is not just a one-off and a doctor doing it by him or herself. We have Dr. Gary Pace on the line, and Dr. Pace, I was wondering if you could give an experience that's a patient story of a before and after, and something that kind of feeds into why this practice is rewarding for you.
Hi, yeah, can you hear me?
Yes, loud and clear.
Okay, great, okay. So, yeah, I'm Gary Pace in Northern California, and we've been providing buprenorphine for over 10 years, mainly in small rural clinics where I was the only provider that was doing it, and sometimes I'd have a behavioral health person that was interested and oftentimes not. And, yeah, I just want to really encourage people to do it. For the most part, most of the cases are pretty straightforward in these smaller areas, it seems like. And, occasionally getting mentorship would be really helpful, but for the most part, once you get a couple of them down, it's very doable. And most of the people seem to do pretty well. I thought of 2 examples. One was an addict who I saw probably 5 years ago or so, who was abusing pain meds, and their primary care provider picked up that they were overusing and confronted him, and turned out he was a heroin addict as well, and that hadn't been recognized before. And so she sent him to me, and the first 6 months or so, it was pretty contentious, where he was kind of manipulating around the meds and everything, but finally he kind of got with the program, and about 2 to 3 years into it, he had completely cleaned up and was working in the family business and got married, and was, it was really gratifying to see him go from this really problematic character and just a drain on society to really being a really great guy that was able to live a normal life, and he was really, really proud of himself for that. The other scenario I wanted to just mention was another patient who was having problems with pain meds. She wasn't using street drugs so much, but she was overusing her meds and was always running up short and coming in with all these excuses. And finally, she had just gotten sick of it and was willing to make transfer over to the buprenorphine, and she's been on very low doses and is actually weaning herself off at this point, and it's just really stabilized, and she got off that whole roller coaster of the ups and downs of thinking about meds and trying to figure out where she was going to get more meds. So, I mean, it doesn't work for everybody, and I'm sure, like, Dr. Hunter has much greater success because of all the support he has, but for the people in my area, this is really their option, and there's a significant percentage of people who really improve with using it.
Thank you. It's very helpful storied life in the field, and I can tell you from my own experience and from everyone I've talked to, the first 5 inductions, you're scared and you think you need a lot of mentor support, and then after you do a few of them, you think, why did it take so long for me to do this? It's just not that hard. And I did want to talk a minute about induction because there was a question about the buprenorphine patch. In our paper, we didn't really focus much on the buprenorphine patch since it is approved for pain and not addiction, but there was a DEA letter clarification that there's no restrictions on using any form of buprenorphine for pain, which could be interpreted as pain of withdrawal. And so there are more providers who are using the Butrans patch, which is a buprenorphine transdermal system. And through this system, you can start someone on buprenorphine without making them go through withdrawal. And so it's a much smoother onset for people who, for example, pain patients who are terrified of withdrawal and would not be willing to tolerate that. So I was wondering, James, if you could just talk a little bit about the Butrans induction and clarify this issue of using it for pain versus addiction and what you know about that process.
Yeah, so the well, let me just clarify. A point is that the detox and maintenance is really where the DEA draws the line. If you're using it for detox or maintenance of opioid addiction, it falls under that category, and it's got to be one of the FDA-approved products. If a patient has a comorbid pain disorder, then you could use any formulation of buprenorphine. The theory behind using lower doses of buprenorphine is that you can actually start it prior to clearing the full agonist. So if you're transitioning somebody from oxycodone to buprenorphine, the usual process is you'd wait for them to have at least mild or moderate withdrawal symptoms before you started the buprenorphine, and that's at the higher doses. Traditionally, we start people at 4 milligrams once they have withdrawal symptoms. If you use a lower dose, they're actually going to be able to tolerate it. Doesn't carry the same risk of precipitating withdrawal. So it bridges that gap, moving from a full agonist to a partial agonist in a way that patients don't have to experience withdrawal symptoms, because they can tolerate the lower dose, and you can ramp it up slowly over time, so it makes it much more smooth.
Great. And so Dr. Howard Hornfield has done a lot of groundbreaking work on buprenorphine. We'll be presenting on June 8th in our webinar at noon, and he'll be going through the Butrans patch in detail. There were several questions that came up in the chat, and we may not be able to get to all of them, so I'm going to do a quick summary. There was a question about when you use home induction versus when in-person induction, and if there's any research on this. So I'm wondering, Barbara and Mary, my impression from what you found out is that a lot of it is based on the clinic. That for example, some clinics do all home inductions, and other clinics do base it on the patient if they're psychiatrically stable or not. Could one of you comment on the home induction and what you found in your research?
Hi, this is Mary. I'm not sure if Barb's still on the call. She was in transition. So, yeah, I think you're right, Kelly. What we found is that, and as I mentioned, a lot of it depended upon some of the resources that are available within the community or within the individual clinic in the case of clinics that we interviewed, and then others were really based on either physician or patient preference and what made sense given the environment in which the physician's comfort and the patient's environment and what worked best for those particular individuals. I think, as Barb noted, in the early research and literature, I think induction was really encouraged to be done in clinic so that you could observe it, and Dr. Gasper may want to speak more to this, or the other Dr. Pace or Dr. Hunter, but more and more people are doing home induction, and as Barb mentioned it, I think Health Right 360, they don't do anybody pretty much in clinic. I think most of the patients they induce are done at home. So I think it's really shifted, and the opportunity to induce at home is more acceptable now, and as long as there's the appropriate monitoring so that the dosage is correct and the patient is taking it correctly. So both were.
I know, Bill Hunter, if you've done the fentanyl patch bridge, and I'm wondering if you can comment on that because it's a similar idea.
Yeah, we're doing this more and more as we launch into patients who are with chronic pain who are on high-dose opioids. We're transitioning them over. We find that we can do with a fentanyl bridge, we can avoid the whole withdrawal thing. The way it works is we transfer people to a fentanyl patch, either 25 mics is better, but we've done it with 50 mics. I haven't done it yet with a 100 mic patch. But and if they're on the fentanyl with no other opioids for a period of time, then since fentanyl is such a strong binder of the receptors, the buprenorphine will not bump them off, so to speak. So we can so we have them come into clinic and take the patch off and put the buprenorphine under the tongue and just wait to make sure there's no adverse reactions for a few minutes. I had a really good example of a guy who had a remote history of alcoholism, very active in AA, who had colon cancer, and then he had chemotherapy, and then he had terrible neuropathy, and he was on Norco for, I don't know, a couple of years, and he just got to where he was wanting it more and more, and he just couldn't stop wanting it. So I talked to him about that. I just had him come to the clinic, gave him a fentanyl patch for a couple of weeks, had him come in, took the patch off, put the buprenorphine on, and he was happy. Texted me back the next day. He'd never misbehaved at all. He keeps going to his AA meeting. So we're doing that more and more, and we're finding it really smooth and less problematic than having people go into withdrawal, especially if they've been on high-dose opioids, and especially if they're older.
I'm glad you brought that up because there was a question about buprenorphine in the elderly and the safety profile for buprenorphine in the elderly for those who are already on opioids versus those who have never taken them before and who might have crippling pain, not a good candidate for NSAIDs, but are very fearful of opioids because of the addiction. Bill, do you want to comment on buprenorphine in the elderly?
Yeah, I have. I don't know the exact number, but I have a number of elderly patients, and it's a situation where people with crippling arthritis and stuff, came to me on opioids, and sometimes one elderly patient, for example, I think she was 76 or something, she would just take them too quickly, and maybe just by mistake or forgetfulness or something, and she would just get kind of nodding out, and her daughter was worried about it. So we switched her around, and everybody was just so much happier. Her pain was better. She was more alert. The doses, I had to fool around with that a little bit, but kept start really low with really low doses and go slow, like 2 milligrams or less per day, and then gradually inching up. That's probably a good situation for the patch too. I think most of those patches have a lower dose than the sublingual formulations, but I think it's got a pretty good role.
James, do you want to comment on the dose issue because certainly the buckle and the patch allow you to go much lower, and I'm wondering if you can say what's the morphine equivalent of the 2 milligram tablet, and then how far does that go down with the buckle and the patch?
Yeah, I kind of talked briefly about this idea of high dose and low dose, and I'll just put it into perspective. High doses, milligrams, for addiction, we're looking around a target of about 16. The low dose that's being used as an analgesic is in micrograms, and buprenorphine has been used as an analgesic in 0.1, 0.2, 0.3 milligrams in other countries for many, many years, and it's terribly effective in that regard. And we have that availability. The transdermal patch is 20 micrograms per hour. The buccal film is, I think it tops out at 750 or maybe 900 micrograms. So there's a big difference in dose between the two. And it's a potent analgesic, even at lower doses. Its relative potency to morphine, it's probably somewhere around 50 to 1. The number may vary depending on the study you look at. So buprenorphine is a lot more potent than morphine, and we can get good pain relief even at the microgram level.
That's helpful. And there was a question about buprenorphine. It is now covered on Part D that was mandated by CMS, so anyone on Medicare should be able to access buprenorphine, and it's widely available in the VA. There were some questions about training opportunities. Many plans are starting to hold trainings, and you could ask your plan. I also put in the chat box several websites that list where you can get online and in-person training for example, SAMHSA, AAAP, which is the American Academy of Addiction Psychiatry, and PCSS, which is the Providers Clinical Support System, has a wealth of resources, including the ability to sign up for a mentor to help you with your first cases, training courses, online education, etc. There was a question about how long is buprenorphine prescribed before you consider yourself drug-free, and this question about are you really abstinent if you're on buprenorphine. I'm wondering if someone wants to address that. Perhaps Dr. Pace? Do you consider people on
Sure, I'm happy to talk about that. This is a big issue with folks that are in the 12-step programs. So oftentimes you can send them to encourage the 12-step programs, and then depending on the philosophy of that group, they may or may not consider them clean at that time. And so, my personal opinion is, having watched these people over the years make these dramatic lifestyle changes while being on buprenorphine, it seems to me that I would consider them basically leading the kind of life, leading a sober lifestyle. And, I don't think it meets the strict definition that the 12-step programs often use. And so part of what I encourage people to do is to find 12-step groups that are able to, that kind of have a more flexible understanding of it, or to at least be quiet about what they're doing when they're in the bigger group, but to find a sponsor who can understand that they're working with a prescribed medication. But it's a little bit tricky because it is breaking down the sort of kind of black and whiteness that the 12-step programs often use. But a lot of sponsors are willing to work with people like this, kind of seeing it as a prescribed medication. And when you just watch the dramatic changes, it seems like a success, even if they're on this. And so that's kind of the approach I take with it.
I'm glad you brought that up, because it's a real problem that was addressed in the paper, that even though we don't have real evidence of social model effectiveness in opioid use disorder, in fact, the death rate is much higher for patients who only use social model as opposed to using medication. There's still a lot of stigma and discrimination in that community, but any addiction professional would tell you that someone on buprenorphine would be considered clean and sober and abstinent. There were some more detailed questions about how to transition from fentanyl and V-trans onto buprenorphine, and we'll make sure that information is available. We can summarize the Q&A and send it to people who registered for the webinar, and we can give you more information on that, or any of you can reach out to me by email, and I'm happy to provide that as well. There was a question about medication-assisted treatment in the emergency department. There are many areas of the county where of the state where the only people who are waivered are actually emergency room physicians, and they're starting to have different emergency departments which are seeing themselves as a real patient-centered place for patients who need addiction treatment as a place to start. The emergency rooms are open 24/7. There was a great study by Gail D'Onofrio out of Yale which showed that people who got buprenorphine in the emergency department were twice as likely to be in treatment 30 days later. And so we don't have time to go into that in detail, but if anyone is interested in this concept of emergency department inductions for buprenorphine, they're being done in Alameda, they're starting in LA, and there's a lot of new interest in figuring out how to make this an option where you could get started in the emergency department and then get handed off to outpatient treatment. So please reach out to me at my email, kpfeifer@chcf.org, kpfeifer@chcf.org if you're interested. Could someone, I'm wondering if, Mary, if you could address the behavioral health requirements, because someone asked, does the waiver require that prescribers have behavioral health on site, or what are the specific requirements in the waiver for behavioral health services?
Sure. Well, I'm not aware of any requirements that mandate the behavioral health services be provided on site in the same location in some sort of co-located, integrated fashion. that the MAT is being prescribed. And Dr. Gasper, you may know differently on this, being a little closer to it, but certainly it's considered a best practice, as we discussed earlier, to have available the behavioral health services along with the actual buprenorphine, so that patients not only get the medication but also the therapeutic support of whether it be a group or individual behavioral health support to help them manage, as I mentioned, sometimes those complicated life circumstances. And I know the waiver does expand coverage of it's my understanding that as the drug Medi-Cal waiver is rolling out that it does include and expand coverage for those services as well as those individuals who can be considered eligible for reimbursement under the waiver. But I'm not.
I'll jump in. I'll jump in.
James, please do.
So the Data 2000 requirement is that you have access to refer somebody to counseling. It doesn't mean that they have to be actively in counseling.
Right.
So that's the extent of it. And the drug Medi-Cal waiver extends benefits in many different directions. And I think one of the opportunities is counties that didn't formerly have NTP services or outpatient drug-free counseling or residential care may now have them, so your local partners may be more accessible.
Great. And I'm wondering, James, are you the right person to answer a question about HIPAA and privacy in terms of if you have buprenorphine in primary care, can you use your regular electronic health record to document that visit?
Yeah, this has been tricky. But what this comes down to is 42 CFR, which says that the substance abuse program can't disclose the fact that somebody's receiving substance abuse treatment. In the case of primary care, you're not a substance abuse treatment program. So it's mostly tied to the location of the services. If we're talking about methadone maintenance, that would not be allowed in the electronic health record, but if it's buprenorphine being prescribed by a primary care doctor in a primary care clinic, then it would be not under the auspices of 42 CFR. And there's a number of issues that have caused the feds to actually revisit this because it was invented many, many years ago before we ever had electronic health records. So they're trying to get some clarity out and put in some revisions so that it doesn't become a way for care to be fractionated.
So
yeah, Kelly,
go ahead.
Yeah, Kelly, this is Mary. I was just going to say what James just did, which is that, the regulations are under review, and a lot of it has to do with the disclosure as opposed to where it's recorded and when you can disclose. And a lot of the people we interviewed in doing, the research paper talked about in terms of working with the patients directly, and I'm sure the doctors on the call can comment on this, that it's just really good protocol and good practice to talk up front with the patient about the issue of confidentiality and disclosure so that you kind of address that confidentiality issue, at least from the perspective of what you'll be sharing and why, kind of up front.
Yeah, I think it's helpful for people to know that, again, if you're not a drug Medi-Cal or licensed drug addiction provider, but you're doing it in primary care, then you are able to include this information in the regular healthcare record. Again, we've had some really great questions, and we will summarize these questions, and any questions we couldn't get to, we'll put in a Q&A form, and at minimum send out to those who are on the call, and we may put them on our website as well. There was a question about hospitalized patients and that many patients are discontinued from their buprenorphine when they're inpatients. Dr. Howard Kornfeld did some great studies on that. If you look on PubMed under Howard Kornfeld, you can see his studies showing that patients who were kept on their buprenorphine had shorter hospital stays. And there's a great study of a tale of two knees, where one knee replacement was done where buprenorphine was stopped, another knee replacement was done where it was continued, and the stay was shorter and the recovery was shorter and the time back to full function was shorter with staying on buprenorphine. I've asked the California Society of Addiction Medicine to put out a position paper, which they'll be doing shortly, stating that buprenorphine should be continued during inpatient stays, and we're hoping that we can spread the word just as more people get on buprenorphine so that they can make sure they have adequate pain control. There was a question about using compounded oral solution for tapering below 1 milligram. James, I'm wondering if you can address that as you taper someone, since the 1 milligram is still quite a high dose. How would you make that tapering on the compounded solution versus using a patch or a buccal form to get people down to lower doses?
If you're tapering somebody with addiction, you still have to use the FDA-approved products. There's basically pharmacy compounding of buprenorphine for the treatment of addiction is disallowed. It's not legal. But what you can do is take the 2 milligram tablet and literally crumble it up. You know, it can be cut into fourths, which will get you down to 0.5 milligram. And even a crumble of buprenorphine can be active, and it's, as I said, it's a very potent medication. So it's not as exact, but dividing up the 2 milligram tablet is possible and can be used for tapering.
I wanted to leave a chance for any comments. So, Dr. Pace, any other comments from your own practice based on what you've heard so far?
No, I think this is really great, and I guess the big thing I just want to encourage people is that the bigger places have a lot of support, and you know, you can get a whole kind of complex, multi-layered program, which is really exciting to hear that. But I think it's also really possible to do this and to provide this service out there. And you know, I guess what I've found over the years is the most important thing is to remove the obstacles. You know, especially for the addicts in the community, they're going to show up and they're ready right now, you know, and it's if you say, well, I have to get behavioral health in place and I have to do all these things, they're going to go back out and use, and you're going to lose it. And kind of the window opens, and to kind of bring them in and to start working with them is been really, for me, the most gratifying thing. And I would just encourage people to kind of do what they can to remove the obstacles, basically.
And it's there's a great study out of Sweden that did a randomized controlled trial where they put some people on buprenorphine and tapered them off quickly, and then they put other people on buprenorphine maintenance. And the death rate in the placebo trial that got tapered off was 20%. And so I heard a great speaker, Dr. Andrew Kolodny, who's going to be keynoting at our fall conference, and all of you will be getting the invitation to the fall conference on September 22nd. In Oakland, and he said if there's any other randomized placebo-controlled trial where the placebo had a 20% death rate, that trial would be malpractice to repeat anywhere again. And yet that essentially that experiment of denying people the opportunity for buprenorphine, for insisting on only social model or drug-free model, or just not providing access, that experiment's repeated across California and across the U.S. every day. And I'm so grateful for all of you being on the phone and showing interest in this. I think you saw a great range of models, from a very well-resourced model with lots of support to Dr. Gary Pace in the rural area, just without a lot of other staff support other than just being a family doc doing the right thing in an area where that's the need is desperate. So again, we weren't able to get to all of the questions, but we will be, over the next week, putting together some Q&As and getting them out to you. As I mentioned, we have another webinar on June 8th at noon for Dr. Howard Kornfeld, and he'll be focusing on the use of buprenorphine in pain, much more of a clinical approach. So for clinicians who are interested in prescribing and getting into some of the details of things we discussed today, like how to use a patch to have a transition onto buprenorphine that doesn't involve so many withdrawal symptoms for those who have a pain diagnosis, how to use small dose buprenorphine for pain. All of those things will be covered in great detail, so we'll make sure you get those links. We'll also make sure you have the links for training opportunities, although simply Googling buprenorphine training, you'll come up with many, many online opportunities that are fairly affordable and easy to do. So once again, thank you to our speakers. All of you, we had a rock star panel today, and we really appreciate everybody's time. Thank you, and we'll close our webinar.